Hi everyone, I'm Dr. Faisel Syed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care. Today, we're talking to Dr. Jay Lee, co-founder of #FM Revolution, about Family Medicine Revolution, Physician Leadership in Action. Let's get started.
Hello, Dr. Dan.
Hey, Faisel. Good to see you.
It's always good to see you. And look who we've got over here, Dr. Lee. So good to see you again. I was talking with Dr. Dan earlier today, and I was just telling him, I feel like this is the best time ever to be a family doctor. We meet people talking about everything that's broken, but look at all the momentum we've got now with direct primary care, AI, value-based care. All this stuff. There's a massive shift happening.
Yeah, I think there's a ton of opportunity in some of the chaos that you just alluded to earlier. And I think in that chaos are those nuggets that we as family physicians who know how to be resilient, know how to have grit, know how to do what we need to do for our patients, will figure out a way to make it so. And I think if we lean into that as family docs, I think there's a ton of opportunity and potential for us to become the leaders that the systems need us to be and that our patients ultimately need us to be.
Yeah. But before we get into talking, there's a lot of things I want to talk about being a family doctor leader and all these things, especially for ourselves. We have a large number of students and residents on different stages of their career and different stages of contemplation. Maybe people who are thinking about going back to school or going into, But so before we get into all of that, we love sharing everyone's story. How did you even end up in family medicine?
Yeah. So years ago, I thought I would do something like Médecins Sans Frontières and read about doctors that would go and, bring a clinic out to the field, out in the bush, and thought, oh, that sounds amazing. I want to do that. And then did spend some time working with a non-governmental organization before going to medical school in post-war El Salvador. I grew my hair long, lost probably about 15 pounds of water weight, and got to do some really good work actually with local Salvadoran physicians, supporting them, taking vitals, sometimes scrubbing in on cases, doing public health work, potable water project. And what happened was, life. I got married. I got a mortgage, and then I was like, oh wait, and there's a lot of work to be done here in the United States, right? And so during that process, I'd kind of gravitated towards working with community health centers and working with those who are populations that are very vulnerable and needing care. And, that's kind of how I ended up doing the things that I do in the spaces that I do at the moment. Along the way, I got a master's in public health to try to understand systems better and how to impact those upstream factors that determine what we do at the distal end of the delivery system. And then, you quickly realize that all the things you learn in the books and the case studies don't apply. But the skills that you learn along the way are certainly applicable, and then give you a sense of hope, a taste of hope that maybe there's an opportunity for us to make some change.
But was there a particular moment where you were like, this is it, I'm going to be a family doctor?
Yeah, so I always thought I was going to do med peds, because I thought, well, I want to see kids and I want to see adults. And in med school, my advisor, who was MedPeds, said, you might think about family medicine, because if you want to do all the things that you say that you want to do, family medicine may be the proper pathway for you. And sure enough, she was not wrong. And I think it opened my eyes. And then it also helped create that connection back to that experience that I had in post-war El Salvador, where, you really are there, you're meeting the patients where they're at and doing everything that you can. Your job ultimately is to extract as much as you can the patient deserves and needs from whatever system you're working in. And, I think that opened my eyes to that possibility. And I think the other piece was that beginning to understand the roots of family medicine as counterculture, as thinking outside, the Flexnerian model solely, right? And thinking about how patients are in the context of their community and their family and their social environment. And then it was like a slam dunk, right? I was like, okay, dang it, this is what I'm going to be doing for the rest of my life.
Jay, I know you've done a lot in physician leadership. So, what does it take to be a physician leader? Because if you're going to be a leader of an organization, you do have to pay attention to the money. And it's not just about getting each individual patient everything you can give that individual patient. But then as a physician, you still want to do right by your patient. So how do you bring those together and do well for both the system and the patient?
Yeah, one of the hardest courses that I ever took in my life, not because the material was hard, but because I had trouble reconciling in my mind, was microeconomics and trying to understand rational thinking and how that impacts the way a care can be delivered, and then trying to Goldilocks how to be the right person in the situation. Because, if you're not in the room or if you're not at the table, you're on the menu. And as a physician leader, I've had the opportunity to be at the table more often than not. And I always make it a point to ground our conversation in the actual patients or patient that may be impacted by an operational change or a way that we change the workforce or change the finances of how we pay our clinical teams, et cetera. And in a weird way, learning how to code switch between those two worlds. The same is true when it comes to talking with health plans, right? In the health center space in particular, particularly here in California, I think there is a lot more opportunity for us to be talking directly with health plans versus just the state. And every health plan has a different flavor. And, I often find myself in a room with people from the health plan and then calling the physician that was at the table on their side afterwards to say like, okay, well, let's really get down to brass tacks here on how do we implement this. And that's all relational, right? Because you find yourself actually with other family physicians sitting on the other side of the table from you. And then you get together and you talk. And then there's that sort of halo impact of the physicians being together as leaders, speaking about the patients, and then trying to make the math work. The math has to work, right?
Were you like this before you got the master's degree? Like, when did you go from being a doctor to like, hey, I want to actually change things?
Yeah, I mean, honestly, I probably was always oriented towards that. I don't know, in every med school class, there's like a small percentage, maybe 5 to 8% of the class that seems to care about something other than studying. And and, I found those people in my class and I connected with them. And a lot of us wrote about changing the world in our personal statements, but none of us really knows what that means when we're young and idealistic, right? And then you realize that it goes beyond just showing up. Like, because I think when you're young and naive or idealistic, you think, oh, okay, if I just show up and speak the truth, then the truth will become so. Unfortunately, that's not the way the world works. And sometimes you do have to have a fight to get the things that your patients need. So I would say spiritually, that was always in me. I learned the hard way that sometimes going in there and trying to fight the good fight is not always is not going to get the results that you need or want. You also have to make a compelling case, and that's not just a moral or emotional case. Sometimes it is being able to back that up with numbers and data, and then being able to kind of thread the needle properly so that you can move both the minds and the hearts in the room.
Yeah, that's always seems to be the struggle. I feel it really painful these days. My oldest is a senior, and and the conversations you can imagine with having a senior, a high school senior, getting in, going to college and all of that, and I cannot believe some of the things I'm saying. I don't want to dampen his spirit, but like I'm always like, well, how is this actually going to work? This is a great idea, but how is it going to work? And he's like, oh, it's the right thing to do. And I was like, okay, well, I've turned it to my dad. Like one of the things with when we're dealing with residents, especially, and just being a doctor leader, like I asked about the master's degree, did you start doing it before or after? Because, do you need a title to lead? I mean, are there some trade-offs? Are there things that you miss before you got into the leadership world?
Yeah, I don't think you necessarily need a title or degrees to go on and assume leadership. There's the leadership that comes from a title, right? And then there's the leadership that comes from being who you are and having people see that in you, right? In many ways, going to get my master's in public health was a terrible financial decision, right? I borrowed more money to go back to school when I could have been making attending money, right? But I would say it accelerated my understanding of how to navigate systems, and then opened some doors early in my career for me to be able to kind of roll up my sleeves and get my hands dirty. And it was an interesting time because when I finished my MPH was just prior to the Affordable Care Act passing. And then these first generation ACOs were coming out, value based care, the concept of it was kind of coming online. And I was in a room with a bunch of other people, including some people in suits. And some person in a suit said, "You seem to know something about that. How about we give you some time to work on it?" And I'm like, okay, let's do it. And there was no book for it, right? Everyone just was like, yeah, you had some knowledge. We're going to give you some time to work on it, and good luck. And, strangely, I would say, like, I really was able to cut my teeth, and I was getting more feedback from the docs than I was from the leaders, the non-physician leaders, because I think, everyone, there's a dopamine button, right? You push it, what you know. If you code a certain way, if you see patients in a certain way, the dollars will roll in and you're comfortable. But, I think if we truly want to be transformative, we're still sitting on a fee-for-service chassis that we're tinkering around the edges and not really moving as quickly as I think we should be or could be.
One of the things we wanted to talk with you about was what was going on in your mind when when you thought of this hashtag with FM Revolution. What stage of what at what time did that happen?
Yeah, so that happened in that period I just was referencing, right after the passage of the Affordable Care Act. And historically around that time, Twitter was still Twitter, and Twitter was also being used in areas of the world where there were revolutions happening, where hashtags were essentially being leveraged to organize people around ideas or events, hashtag FM Revolution, we're going to be here, that kind of idea. And so I toyed around with the idea. We actually, if our specialty is rooted in counterculture as the reason for why we exist. Early leaders in family medicine, including folks like G. Gale Stevens, who famously wrote about family medicine as counterculture, allowed us to think about how to break free from that flexnerian model that I had mentioned earlier, to really think about the patient in the context of their community and their family, et cetera, in the ways that we've been trained to think about them. Full credit to a group of residents in Santa Rosa, California. They kind of caught a little bit of that bug, and they were showing up to meetings with t-shirts that they printed themselves with their own money that said things like, use your whole brain, become a family physician, bring sexy back, be a family doc, stuff like that. That was kind of cool. And their t-shirts at the California meetings would just sell like hotcakes. I mean, they would just they get sold out. They'd make their money back. And in their wisdom, they came to the CAFP, the California Academy of Family Physicians, and said, hey, we're graduating. We think this idea has some merit. Do you think you all could take this on? And so the foundation side of CAFP took it on. And I was the new physician board member at the time. And they said, the membership person said, hey, there's this thing called the Twitter. Do you think you could get on it and figure out like how it works and see if you can do something, in the family medicine space? And so that's kind of how we came up with this hashtag FM Revolution, because it was, short enough. It sort of encapsulated the spirit of what we did. And as I learned in reading some of the earlier works from our specialty, it very much harkened back to the roots of who we are and the reason why we exist today.
Did you ever expect in your wildest dreams that it would blow up the way that it did?
No, no. I mean, it's like a garden that maybe you get started, and then in spite of your best intentions, it continues to flourish. Because
My
I
wife
mean,
has a knack for that. My wife has a knack for plants that thrive on neglect.
I'm a busy dude. We're all busy people, right? And somehow
Yeah.
the hashtag lives a life in spite of our best efforts. So I'm cool with that. I'm totally fine with that.
Why do you think it resonates so much though?
Yeah, I mean, I think it resonates because of our why, because of why we have entered the field of family medicine. A lot of us are mission driven. And I think, especially with so many things coming at us that could be perceived as negative in the external environment, coming out at our way through, via the medical industrial complex, I think we're all trying to find some meaning in the world that keeps us going, that keeps us connected with our patients. That time that I'm in an exam room like the one behind me with my patient, I'm not worried about anything else other than my patient, right? And that's why we got into what we got into. And is there some way of preserving that? And I feel that's the promise of family medicine revolution, is to get back to that primacy in spite of all the fragmentation that we see in the system today.
Do you think that's why, like so many of us, like so many family doctors, like we don't value, I mean, like, we underestimate how much influence we actually have. I mean, I feel like every time I go to a national conference, right, you'll go to, like, we feel like it's like a recharging at the end of it. Every time to make the logistics work, Dr. Dan and I are like always like, oh God, we got to go do this. And then afterwards we'll look at each other. I'm like, yes, I'm so glad we did the field. We're energized again. Like, but do you think that too many of us underestimate our influence that we actually have, like whether you're in a clinic or a system, a health system?
I mean, I think that's fundamentally part of what the revolution is about, right? It's about rediscovering our voice. As a medical student, I was a bit of an activist. There's some analog somewhere of me with healthcare for all emblazoned on my chest with Sharpie at a protest. And thank God there was no social media back then, but
Oh God, a doctor who wants people to have medical care. I mean, God, that's a career-ending move these days. It would be, we don't want that doctor. It's crazy, right? What a world we're living in.
But this idea of finding our voice, being able to tell our own story, I don't necessarily want a neurosurgeon or a cardiothoracic surgeon to be telling my story or the story of my colleagues. I want family physicians to own it. And because social media can be so democratizing, there's an opportunity for us to use our collective platforms to elevate the voice of family medicine. And I honestly, I'm beginning to see it in some of the younger generation of family physicians, kind of the anti-influencer, if you will, right? And they're coming and they're bringing cool ideas. They're presenting it and packaging it in new ways that are very relatable for patients. And I think that's the magic of what we do. We have to kind of fight back.
Jay, I know you've been talking a lot about advocacy and a lot about leadership, and you work in both. How are they same and how are they different? And what do you need to bring to each one to be successful?
Yeah, that's a great question. In a lot of ways, leadership is, particularly in an organizational context, is knowing what levers to be able to pull, from an operational perspective, knowing what targets to set, et cetera, and doing it, I think, to the extent that you can be a vulnerable human. It's hard, I think, for us as physicians to kind of embrace that as strength. But I believe, this was particularly true during the pandemic, where there were times when I just said to my team, I don't know what the right answer is, but this feels like the right thing for us to do because it's the right thing to do for the patient. So let's go. And then you line up the resources to make it happen, right? So I think there's a bit more of an organization or operational element to leadership, and some of it's inspirational, but I think a lot of it is about making sure that the team is working to their best. Advocacy is slightly different in that who you're trying to convince to move are not the people that you lead. It's others who may be in a position of power. The timing of this is actually perfect. I just got back from Sacramento with the California Medical Association for their physician leadership day or Physician Advocacy Day. And all of us in our white coats were walking around the Capitol, meeting with legislators, talking about things that are of importance from a policy perspective for our patients and for our colleagues. And, it's beautiful when you see that, medicine and doing the right thing for the patient is not a partisan issue. Whether you're going to a Republican office or a Democrat office, you're presenting it as a physician, you bring that credibility and you bring the voice for the patient. And, your hope is that that law or that bill that they want to turn into law reflects the values that you're bringing to the table and doesn't hamstring us from doing the right thing for the patients. And so it's very similar, but also, I would say in many ways different. But I think you almost have to be able to do both, kind of like a biathlon. You got to be able to ski and shoot, right? To be able to make things move. Because those upstream factors, those policy issues, do very much impact our ability to deliver care on the distal end of the delivery system.
I love that, and I love just especially with the younger doctors. I feel like a lot we're getting more involved in the political discussion. Especially, I feel like the direct primary care movement basically has helped us so much, just move us. Like I was shocked when we first learned about, now patients can use their health savings account, flexible savings account to pay for their, the monthly memberships. I feel like for so many of us who just hate billing and hate everything about billing, like it's great. I mean, who would have, that's another wild idea that's allowed us as doctors, and we're not, business people, to redesign the way that we practice.
Yeah, I mean, it's not surprising that direct primary care is one of the largest or the fastest growing segments of membership amongst family physicians. And, I think if you're even a little bit entrepreneurial and, want to have time with your patients and, want to build those relationships and essentially grow up to do the things that you wrote about in your personal statement, I think DPC is a great option for folks. And I see that's true irrespective of what generation you may be in. I would say like Gen X and Boomer docs that I know that are in DPC, very much value that sort of independence, right? To be able to craft the way they do things. And then there's the emerging generation, millennials. Millennials are fully here, but I would say Gen Z, part of the group that I was with up in Sacramento were medical students, and many of them don't want to be part of that larger medical industrial complex. They want to go back to their community and provide a level of service that's personal and feels almost like, Marcus Welby-esque, even though they would never know who Marcus Welby is. And they want to do it with like a Steve Jobs mindset, right? They want to use technology to secure message with their patients. They want to do video meetings with their patients. They want to have wearables for their patients so that they can monitor them. I mean, it's like old school, but it's also new school. And I think there's room for all of that. I mean, I don't think DPC is right for everybody, but I think that it's definitely an option for those who don't feel like they see themselves in that medical industrial complex, whether that be on, the sort of vertically integrated medical group side or, even in some FQHCs, particularly in larger ones where you might get a little bit lost because you're not the sort of individual that you think you deserve to be.
You brought up Marcus Welby, so I'm really going to show my age now. So his younger partner, I think the character's name was Richard Kiley, and he had longer hair and rode a motorcycle to make his house calls and go to the hospital on. So that's really what you're talking about. The younger doctors are using the current technology to be that younger person to take the relationship and use the newer technology in a different way. So maybe it's not a motorcycle, maybe it's AI now. But anyway, since you brought it up, I had to build on it a little bit.
No, I love that. And I think ultimately the thing that we recognize in Marcus Welby as a character, right, is that the humanity that he brought to the work that he did with patients. And another famous family physician from entertainment is, Bones, right? And he would famously was the curmudgeon who said, damn it, Jim, I'm a doctor, not a dot, dot, dot. I think there's a whole generation of docs who actually don't think like that and want to be that bedrock in a community. The office where I'm at right now, this is a DPC that's been around for 10 years, and it's a husband and wife group that started it from an idea, and it's now 6 docs in the clinic, and everyone practices in their personalized way, but we're all on the same page about wanting to do the right thing by our patients.
With everything that's going on, I mean, we're clearly feeling a change. I feel like this is the best time to be a family doctor. Really, this moment, I feel like a superhero with all the tools, with the ambient AI, open evidence, like all these things that are out there. Like we can really influence. I don't know. Like when we've been more influential, seriously. But like for your magic ball question moment, in the next 5 years, it's 2026 now. Let's make it 4 years, 2030. Where do you think primary care is heading over the next 4 years?
Yeah, I mean, so hard to know what's going to happen in the external environment, right? But I do know that several things need to happen in the next 4 to 6 years, right? And I think there's some states where they're beginning to move in this direction, and that there's some states where it's not quite happening. But I know that there's a lot of energy on the national front to see things like primary care investment increase, right? And the general public thinks that we spend 50 cents, 50 cents of every dollar in primary care. That's super cute. We all know that it's actually 5 cents, right? It's an order of magnitude less. But states like California want to move it to 15% of spend. And, I think both NAC and the AFP have talked about doubling that spend, in that period of time. I think we also really need to focus. It's not just about spend. And I would say the spend is not just physician salaries. It's like all the team members that need to be around a doc to make the magic happen. The other piece is the workforce. And I think a lot of that is in fact, it's physicians because we are going to be short. But it is also the other team members that are trained up to do not just widgets of care in a fee-for-service mindset, but to do all the care that needs to happen, particularly in those interstitial spaces between visits, right, that are technology enabled, that allow us to communicate better with the patient, right, and that can help us prevent hospitalizations and unnecessary ER visits, et cetera. So there's a spend, there's workforce, and then I would say like the third piece is really around reach, right? Like I think reach happens on a number of fronts. One is it's access, right? So, when I worked in Massachusetts, the year Romney Care was being implemented, people would come into urgent care at midnight and they'd be like, I got this card, but I can't get in and see my doctor. So the card was part of the equation, but, you also got to build systems to be able to accommodate those patients coming in. And then the reach for me is also like just thinking about it beyond office visits, thinking it beyond, units of care. How do we amplify what we do in a way that really moves the needle on reducing heart attack and stroke, reducing amputations from diabetes and those types of things? And the math has to be different than just counting the number of visits that a patient has, right? So I think those are the 3 fronts where there's a huge opportunity for us to be moving towards. And it's been termed by Asaf Bitan that this is the triple double in primary care. And, there's 3 areas that we need to double, and that's in spend, in workforce, and in reach. And I think there's a huge opportunity for us to move the needle. And even if we don't double those 3 things, if we get to, 40% more, I'd be okay with that. But you got to set a target to aim for something, right? And so that's my hope in the next 4 years, that in the next Olympiad that we get there.
There you go. Well, gosh, Dr. Lee, thank you so much for taking the time to join us today. It was a great conversation.
It's an honor and a pleasure, and I look forward to continuing to do the work together with you and our colleagues from around the country. And long live the family medicine revolution, guys.
Oh, right. What are your thoughts on family medicine revolution, physician leadership in action? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.